Coaster. We're so glad you're joining us today. I have a guest named Sam Socco. She is a pharmacist with Myriad Genetics. That's the parent company. And then she works for GeneSight, which is one of their, I guess, sister companies, I guess you could say. But she's here today to talk to us about pharmacogenomics. I've heard this term quite often, but honestly, I really don't know what it is and how it actually benefits us, applies to us. So I invited Sam on today. So welcome, Sam. Thanks for coming.
Hi, thanks for having me.
All right. Well, I think first let's just start off. What is pharmacogenomics?
Yeah, that's a good question. So, really, pharmacogenomics is looking at how somebody's underlying DNA can impact how they might respond, how they might process to different medications. So, everybody has their own unique DNA sequence, right? And there are certain genes that we have that code for things like a drug metabolizing enzyme. It could be a receptor or a transporter, areas where medication interact with to impart their mechanism of action. And these genes sometimes have these variants that we find where there's these little changes in the DNA that some people have that causes that final protein product, that either the enzyme, that receptor, that transporter, to function a little bit differently than it normally would. And so, for example, somebody could have a mutation in a gene that's coding for the CYP2D6 enzyme, which is an enzyme that metabolizes a lot of different medications, including antidepressants and antipsychotics, a big class of medications that goes through that enzyme. And this mutation can make it so that that enzyme is not working very well. So it's not able to process those medications in the same way as somebody who would be considered a normal metabolizer who doesn't have that mutation present. And so because of that, if you give somebody a medication that goes through that enzyme and you're giving them that normal starting dose, but they're not able to actually metabolize the medication because that enzyme just not working right, then what we start to worry about is that that medication can kind of build up in the body, and then we worry about side effects potentially if the person's just not able to kind of get rid of that medication. So that's just one example of a gene that we would look at in the realm of pharmacogenomics that could impact like how somebody is processing a medication, how we might want to dose that medication. There are considerations sometimes we have to make with certain medication classes, depending on some of these genes. So, in a nutshell, that's really what we're talking about when we're talking about pharmacogenomics.
Okay, so when I'm hearing you talk about this, it's about metabolizing medication, making sure that we're getting the full efficacy, making sure that we're limiting potential side effects from the correlation between different drugs. So obviously, as breast patients, we take a lot of different medications. Oftentimes, a lot of us take AIs, aromatase inhibitors.
Yeah.
So, but I talk to different girls, and sometimes some have certain side effects, some don't, some work, some don't. So, as a patient, is this testing available for everyone, or do I have to have certain criteria to be available to that? How does that work?
Yeah, so it kind of depends on where you're being seen, and what you're trying to use the testing for. So not all medications have pharmacogenomic information available. And that
Okay.
could just be that we just don't have the data right now, and there isn't enough research to tell us that there's a specific gene that's going to impact that particular medication. It could be that that medication just doesn't really go through the liver for metabolism, and so there might not be as much, available, and these pharmacogenomic variants might not really be impacting that medication to a significant extent. So it depends sort of on which medications you're taking and if there is potentially pharmacogenomic information that can be useful to that medication. That's kind of the first piece of it. The second piece is if you are being seen at a facility that is able to do pharmacogenomic testing. So there's, a few ways this can be done. There are some hospitals where they do have their own kind of in-house testing, and they have certain genes that they're testing for there, where the provider can just order it, it can get done at that hospital. And then there are providers that will use external testing. So, like for example, I work for GeneSight. This is a test that the provider can order for their patient, and they will take the patient's saliva sample in clinic, but everything else is kind of done externally via the GeneSight laboratory. And so those results will ultimately be given to that provider. The provider will get the test results. Then they can share that with the patient. The patient go over those results, and then the patient can request that report for themselves to have it. But yeah, there are, external pharmacogenomic tests that a provider can potentially order depending on if it's going to be applicable to that patient.
How do I know if the test is applicable to me?
Yeah, that's a good question. I would say, have that conversation with your provider, and just ask if they're aware of, pharmacogenomic testing that might be applicable to the medication. There are resources that exist that you can kind of go to see just kind of which medications are primarily being impacted by pharmacogenomics. So I can certainly like go through some of those resources. Some of them are a little bit high level, so it might not be super patient friendly. But overall, what I can say is that there are a few medication classes where we have pretty established evidence in terms of the utility of pharmacogenomics. So depression is one of those therapeutic areas where we have pretty good information. So um, having information regarding different antidepressants, antipsychotics, that's an area where there's utility. Pain is another. So there are certain opioid medications that can be impacted by pharmacogenomic results. So that's another kind of broad therapeutic area. Oncology is another. So there are certain chemotherapy agents that potentially dosing can be informed per some of these pharmacogenomic test results. Um, there is a little bit of information as well for CYP2D6 with tamoxifen. So that's one gene drug pair example that could be applicable to specifically breast cancer patients. Um, and so those are kind of the main areas. We have a little bit of information with some of the cardiovascular medications. It's not as extensive though as with pain, depression, and oncology. Yeah.
Okay, so that's a good example. I know, like, I was on tamoxifen for 10 years, and I know that one of the side effects just from reading it when I started taking it was depression was one of the side effects. And so obviously we're shutting down all our estrogen, things are happening in your body. So then I get on an antidepressant, but the one that I was on, my oncologist had to switch because it was on the same transmitter
Yeah.
as then. So could that have been a potential way that this testing could have been helpful to know that? Or is it really more of the way your body metabolizes the medication?
Yeah, so I think like both can be informative. So what they were looking at there was more of a drug-drug interaction, right? So you have an antidepressant that's primarily either going through CYP2D6 for metabolism or potentially inhibiting CYP2D6 for metabolism. CYP2D6 is the main enzyme that is activating tamoxifen. So there is an interaction that's happening there that potentially is going to make it so that you need to be on a different. So that's one piece of it. The
Okay.
pharmacogenomic piece of it will tell you at baseline, per your gene, are you a normal metabolizer of CYP2D6 already anyway? So that's another important piece because even if, let's say, you come off of that antidepressant that is potentially inhibiting that enzyme, interacting with that enzyme, right? It's still useful to know, are you a normal metabolizer at this enzyme, and are you able to activate tamoxifen as somebody who is a normal metabolizer? So the main kind of interaction here with CYP2D6 and tamoxifen is actually related mostly to the efficacy of the medication. And so if you have somebody who their CYP2D6 enzyme doesn't work very well, there is potentially a concern with being able to activate that drug. And so what I mean by activate is when you take tamoxifen, it's not in its quote unquote active form. So the way the parent drug is it doesn't really do what it's supposed to do. It actually has to go through this enzyme. It becomes an active metabolite is what it's called. And then it's able to do what it's supposed to do. Right. So if you have an enzyme that's not working very well, like we would consider that like a poor metabolizer is you would be called if your enzyme just doesn't work well because of your genetics. Um, there's usually when that's the case, we worry about side effects with drugs because if you're not able to get rid of that drug, you're a poor metabolizer, that drug can start to build up. We worry about side effects. In this
Mhm.
case, this is one of those kind of weird exceptions to that. So if you're a poor metabolizer here, we are worried that you're not activating enough of that tamoxifen and that there could be an impact on efficacy of the drug. So this is one of those situations where it's really important to have a conversation with the provider and to come to, you know, an informed decision together, patient and provider, on what to do with scenarios like that. That can be a little bit tricky because I'm sure, as you know, with something like breast cancer and being treated with tamoxifen or an AI, we have some options, but we don't have a lot, right?
Right.
So it's really important to kind of weigh the risk versus benefit on something like this. But it can be really, really useful to have that information on the sensitivity enzyme, just so the provider is aware of it at the
Right.
same time.
So when would I ask this? Like, so let's say somebody listens to this podcast today, they start to learn about it, and they're like, I didn't even know that was a thing, but like, what should I be looking for to even determine if I should ask to have this done?
Yeah, so I think if you're being seen by a provider and you're being I can talk mostly to the like side of things, although I can speak a little bit to some of the other therapeutic areas. But you're being newly started on a medication that is potentially going to be impacted by a pharmacogenomic test result. So could be an antidepressant, could be an antipsychotic, it could be an oncology agent, potentially could be a pain medication. Those are the kind of heavy hitters. There's some information we have for some nausea medication, Zofran being one of them. Um, and some GI medication as well. So proton pump inhibitors, which are things like omeprazole, those medications can sometimes be commonly used for patients that are dealing with different types of cancers because of some of these side effects that you're having from chemotherapy, right? So I would say, if you're being started on a new medication that might fit into one of those categories, it could be worthwhile to bring that up to your provider. Like, hey, I'm just curious, is pharmacogenomic testing something that would help inform therapy with these agents? Is this something that you are comfortable using for me, ordering for me, and just having that open discussion with the provider?
Okay. And then how much does it cost to have this testing done?
That's a good question. It kind of depends on the test. So again, there are some places that will do in-house testing. And so that it depends on like, what they have arranged with the lab and how that's all a part of whatever the patient is being charged for their visit. But when it comes to outside testing, every external lab is a little bit different. So I can speak personally to GeneSight, how much that costs. And I would say that for some of the other testing companies, it could be similar. It might be very different. Kind of just depends. Typically, this is something though that you'll be able to see like on their website. Honestly, it's usually pretty transparent. So for GeneSight, we have what's called the GeneSight promise. So most patients are going to pay $330 or less for their test. And what's kind of nice about something like GeneSight is that it's it we do have $0 out of pocket costs for patients that are Medicaid patients. So if you're on Medicaid or traditional Medicare, that's $0 out of pocket for patients that are on either of those insurances. Um, for patients who have commercial insurance, we also have a kind of like tiered payment system. So depending on what your household income is, you might end up paying less than that 330. So it might be $100, it might be $200. And that's something that you could, call our customer service line with and talk to somebody on our payment team to see potentially what your cost is going to be based on that household income. But again, majority of patients are paying $330 or less. And that's kind of what we have for GeneSight. But it can be different depending on what you're using.
Okay, that's cool. So, um, let's just say I'm not on a medication yet, or we're talking about maybe getting on something. Like me right now, I'm not taking anything. Would that be beneficial for me to know now, just for future, or is it really like when you're currently taking medication that you should even look into this?
Yeah, that's a really good question. That is talking about should we be doing what's called preemptive testing or should we
Yeah.
be doing what's called reactive testing, right?
Yeah.
So I think that there is utility to both. Now, what I will say is that most of the evidence that we have towards utility of pharmacogenomic testing, so most of the studies that have been done in this involve patients that are getting more reactive tests. So, for example, with a lot of the studies that have been done through GeneSight, specific for patients with depression, for these patients to even be enrolled in the study, they had to have already failed at least one medication. And so
Mm,
that's really where we have most of our evidence towards utility is with that patient population that has already kind of tried and failed at least one medication.
mhm.
On the preemptive side of things, we don't have as much evidence showing us that there's utility of pharmacogenomics for that population. However, there are, certain facilities, certain healthcare systems that will do more preemptive testing, especially if they have a patient population that is interested in doing this type of testing, there are some places that have like pharmacogenomic clinics where patients can just go in and request that testing. And so the potential benefit of having that is you have that information up front. Hopefully, it's stored in a way that providers will have access to it regardless on where you're being seen for care, which could potentially be an issue, right? So it's important that the patient has access to that information and they're able to bring that with them to whatever appointment they're going to, whatever facility they're going to. But the potential benefit of that is if you get started on a medication, let's say 2 years down the line or something, that the provider already has that available to them. So there is a potential interaction with your genetics that provider will have, and they don't have to worry about waiting for you to get started on something and then maybe having a side effect, having issues with the medication, and then being like, okay, maybe we should think about ordering pharmacogenomic testing. So I would say that, this is very provider dependent. It is up to the clinical discretion of the provider on if they think that you would be well suited for having preemptive testing versus just waiting for more of that reactive testing. And there's definitely pros and cons to either way.
Okay. So, I mean, I felt like in our disease side, especially with the AIs and the depression, both of those components, sounds like you guys have a lot of research in both. That I know so many ladies who get on something and they have to do a failure before they get switched
Yeah.
over to it. So I feel like preemptive testing really would be beneficial, I think, to a lot of folks. So if you said talk to our provider about it, and then from there, let's say we do move forward with the process, you mentioned that it's basically just a saliva test that's sent over to you guys. Is that right?
So for GeneSight, yes, we do. It's a cheek swab. So you have a little Q-tip, you just kind of swab the inside of your cheek, and then that sample gets sent out, and we run it. And again, kind of depends on what test you're using uh, on how this test is going to be run. For GeneSight specifically, it is pretty much that it's just looking for certain spots in the DNA where we know that there's a potential variant that can impact how you're processing these medications. So it's going to look at these spots in the DNA and it's going to report on that only. There are other tests that can be run where it's what we call either whole exome sequencing or whole genome sequencing, where basically your entire DNA strand is being sequenced. That's another way to do this. Now, with that type of testing, a lot of the time that information is just kind of stored, and then you'll get a report that shows you whatever relevant genes there are to the pharmacogenomic space. But the rest of that information, all the other sequence information on the DNA, it's kind of just stored and sitting there. So it's not exactly going to be useful, at least right now. But those are sort of the different ways that the testing can be done. So yeah, for genes that specifically though, it's a cheek swab, and then that gets run looking at those specific spots in the DNA. Then that information gets sent back to the provider, and the provider can share that with the patient.
And what's the turnaround time on that usually?
Usually for GeneSight, it's around 72 hours on average. It's pretty quick.
Oh, yeah.
Yeah, sometimes there are exceptions. So like if we're missing like insurance information or something like that, then there can be a little bit of a hold up. But typically it's around that.
Okay. So I know we had talked about talking to our provider, but I know a lot of us have genetic counselors in the clinics that we go to. So could this be a conversation that we have with the genetic counselor as well, or should we really start that conversation with our oncologist?
100%. You can talk to a genetic counselor about this. I think that they are very well positioned to be able to have these discussions. They are familiar with pharmacogenomics, and that I think they'd be able to answer a lot of the questions that you have.
Okay, awesome. Well, Sam, I really appreciate you coming on today and just helping us understand what pharmacogenomics is and really what the benefits of it could be for us and how to get access to it. So, thank you so much. I really appreciate it. And if you guys have any questions, feel free to reach out to me and then I can run that by Sam. Or, like she said, reach out to your oncologist or your genetic counselor and might just look into it because I think this could be something that might be really beneficial. So, we look forward to seeing you guys next time.